Hello everyone and very good afternoon. I am Sajid Iqbal and today I am presenting my research paper titled Thwarted Belongingness, Perceived Burdensome and Risk for Suicide Among Patients with Substance Use Disorders. Suicide accounts for nearly 1 million deaths every year. One of the most empirically tested models of suicide, the interpersonal psychological theory of suicide, suggests that suicidal ideation arises when a person feels that they are a burden, perceived burdensome, and do not believe to those around them. That's called thwarted belongingness. The transition toward lethal suicide behavior becomes likely when one feels hopeless that the situation will improve and develops an acquired capability for suicide. That is, when person becomes familiar to physical and or psychological pain and overcome the fear of death. So basically, as I told that my topic is thwarted belongingness, perceived burdensome and risk for suicide. So I will explain how thwarted belongingness and perceived burdensome leads a person towards active suicide. There are two types of suicidal ideation and suicidal behavior that we also called as passive suicidal ideation and active when actually someone attempt to kill himself or herself. Substance use disorder is defined as a chronic relapsing brain disease characterized by compulsive substance seeking and use despite harmful consequences. These consequences include but not limited to physical complication, which can include physical injury, overdose, cardiovascular health problems, loss of hygiene and routine. Chronic substance use can lead to mental health issues such as depression, anxiety, psychosis, and suicide. It can also change relationship to the people closest to the person, affect the quality of life, create financial difficulties, and can lead to person involved in criminal activities. Substance misuse is associated with an increased risk for suicide. Data from the Veterans Health Affairs revealed an elevated risk for suicide for all substance use disorders. Studies suggest that the relationship between substance misuse and suicide ideation is mediated by perceived burdensome and thwarted belongingness. Perceived burdensome and thwarted belongingness accounted for the relationship between problem alcohol use and career suicidal ideation among firefighters. In outpatients participating in substance abuse treatment, the combination of thwarted belongingness and frequent alcohol use was associated with the greatest risk for suicide ideation. There is also evidence that the effect of cannabis use status on suicidal ideation was no longer significant after controlling for perceived burdensome and thwarted belongingness and their interaction in cannabis smokers. Fewer studies examined the association of substance misuse with acquired capability for suicide. The severity of alcohol misuse was associated with general fearlessness, pain tolerance as assessed in college students. Taken together, the studies suggest that perceived burdensome and thwarted belongingness mediate the relationship between substance misuse and suicidal ideation. More research is required to determine whether the same holds true for acquired capability for suicide. Following were the objectives of the study. First, we examined the association and contribution of thwarted belongingness and perceived burdensome onto suicidal ideation in people with substance use disorder. And second, we examined the moderating role of acquired capability for suicide between the relationship of desire for suicide and suicidal behavior in people with substance use disorder. Following were the hypothesis. Thwarted belongingness will predict suicidal ideation in person with substance use disorder. Second one, perceived burdensome will predict suicidal ideation in person with substance use disorder. And third one was acquired capability for suicide will moderate the relationship between desire for suicide and suicidal behavior in person with substance use. The sample of present study comprised of 200 individuals with substance use disorder. They were recruited from different drug rehabilitation centers situated in different cities of Pakistan, providing inpatient and outpatient services. The age of the sample was ranged between 15 years to 50 years. Following was the inclusion and exclusion criteria. Patients who meet the following criteria were included in the study: age 18 years or older, currently diagnosed with substance use disorder. According to Diagnostic and Statistical Manual of Mental Disorder (DSM-5), and accepted the participation in the study. Exclusion criteria included the following: the patient had a non-psychiatric diagnosis before being diagnosed with SUD. The patient was mentally retarded or has an organic brain disorder, and the patient has a chronic medical illness. These were the measures we used to collect the data from the sample. Semi-structured interview form was used to collect demographic information, interpersonal need questionnaire, suicidal behavior questionnaire, and acquire capability for suicide scale. Procedure permission from authorities of drug and rehabilitation center was taken. Consent from for family member caretaker was obtained. Briefed about the purpose and significance of the study, confidentiality of the information, and the right to withdraw participation. Formal consent was obtained through consent form. After consent from the family and the patient were approached. Statistical analysis, simple regression analysis, and Preacher and his moderation model were used to test the hypothesis of the current study. Descriptive statistic for continuous variable and frequencies and percentage for categories variable were also be computed. So this is was the demographic characteristic of the sample. Gender, all were male, education level, metric, intermediate, and graduation. So I am not going to explain. Family history, 23 patient out of 200 said they had family history of substance use disorder. That was 11.5%. And duration of drug use 1 to 3 year was 82, 41%, 3 to 6 year 52, 26%, 6 to 9 year 21, 10%, more than 9 year were 46, that is 23%. And drug of choice, marijuana 68%, opioid 32, polydrugs 47, and ejecting drug user were 53. So these are the results. Summary of linear regression analysis with thwarted belongingness as predictor of suicidal ideation, as you are seeing here, that thwarted belongingness significantly predict suicidal ideation, and this is the coefficient for linear regression analysis. This is summary of linear regression analysis and perceived burdensome as predictor of suicidal ideation. This also variate the 61% change of the score. Here is the moderating, as I saw that acquired capability for suicide is the thing that lead a person towards actual committing suicide. As I said that two of my independent variable, one was thwarted belongingness and second was perceived burdensome. So when a person feel disconnected from his social or family environment, and he or she perceived him or herself as a burden on other or on the society, he may had developed suicidal ideation but it's not necessary that he or she will commit suicide. That is acquired capability for suicide. Acquired capability for suicide is something we can say that when a person becomes fearless to take his or her life. So, perceived burdensome and thwarted belongingness can produce what I say passive suicidal ideation, but it is acquired capability for suicide when he or she becomes fearless to taking off his or her life. Then actually he commit or had suicidal behavior. So these all three hypotheses were approved on the sample I recruited for this study. All the three hypotheses were approved. The current study demonstrated that perceived burdensome and thwarted belongingness significantly predict the suicidal ideation in a sample of person with SUD in Pakistan. These results suggest that when person with substance use experience perception of being burdened, they may be more likely to experience thought of suicide. It further suggests that acquired capability for suicide significantly moderate the relationship between desire for suicide and suicidal behavior in person with substance use. Patients with SUD are at heightened risk for suicidality. Clinicians who provide treatment should be fortified with evidence-based assessment and prevention strategies to effectively manage suicide risk. Identifying the risk and protective factors that influence the potential for suicidality in the person with SUD is a critical step in this direction. Implication and recommendation. Finding from this study may contribute to an initial framework for assessing suicide risk in patients on identified risk and protective factor and the strength of these associations. By identifying prospective factors associated with suicidality and differentiating between factors for suicidal thoughts versus action. This study will potentially contribute theoretically to our understanding of the causal factor involved in influencing increasing level of suicidality. The study results also have the potential to inform and expand current theoretical model of substance-related suicide. Furthermore, it may impact clinical approaches to the management of substance use and suicide with important implications for public health policy. That's all from my side. Thank you.
So can you please explain a little bit in details the exclusion criteria? I'm just very curious. How did you kind of like pick these criteria to exclude patients? For example, someone was previously diagnosed with a psychiatric disorder or so on. So can you please like justify?
Yes, firstly, we recruited these patients from drug rehabilitation center. They were taking aftercare services from these hospitals, so they were assessed. We go through their psychological testings, and all those patients who were diagnosed with any psychiatric disorder were excluded from the service to participate in this research because many other psychiatric illness like depression, bipolar disorder that have a capability or have chances of suicide or even depression have suicidal behavior or thoughts. So we excluded them from this research. We only recruited those patients who were diagnosed having a disorder, substance use disorder, but they were not mentally retarded or any disability, the physical or mental health disability, or they have or had any psychological disorder previously, they were excluded from to participate. And only those were included who were diagnosed with substance use disorder only. Dual diagnosis, if someone had dual diagnosis, they were not included in this research. That's clear.
Yeah, thank you. So that is I just want to follow up a little bit. So that is the patients, though were officially like diagnosed by a doctor or a psychiatrist,
Yes.
right? So how about the patients that were not diagnosed, that have potential to still have like suicidal ideation, but not necessarily screened or diagnosed? What were your thoughts about that?
That were not included in the study. We only recruited those who were formally diagnosed with having a substance use disorder. Only diagnosed patients were included in the research. And we taken all the data from the treatment center providing these services in Pakistan.
All right, thank you.
Oh, thank you.
I have a follow-up question. Thank you so much for your presentation. I noticed in your demographics that 100% were male. Was
Yes.
that as a result of the exclusion factors? Does that mean that there were no females at that specific site that were diagnosed with substance use disorder?
Yes, in few cities, I basically was collecting data from Faisalabad district and Multan and other areas. So there are only few centers who are providing treatment to females. So initially we tried, but many females were not ready to participate. So if we have only fewer females and all other male, so we thought that it would be difficult to calculate the results, that if we had a few female patient and more male patient, then how we will compare them. So it would be an extraneous variable. So we exclude only few females, and we included only male patient in this study.
Thank you.
Okay. Thank you. Thank you so much.
Next speaker is Dr. Saleem. Dr. Saleem is a clinical psychologist, and he worked as clinical psychologist at the psychiatric rehab. Riphah, thank you, Riphah International University. So his background is complete his PhD in clinical psychologist, and right now he is an instructor at Department of Psychology, Riphah International University. Okay, welcome, Dr. Saleem.
Bismillahirrahmanirrahim. Thank you for a short but brief introduction of mine. Thank you very much. I am Dr. Saleem Abbas, Head of Department of Psychology, Riphah International University, Faisalabad campus, Pakistan. I have done my PhD in clinical psychology from University of Karachi, and after that I have completed my ICAP 1, and so my clinical experience is about 9 years or 10 years. I started my job first as a clinical psychologist and psychiatric rehab practitioners by 2011. So with my colleagues and others, I must appreciate. My topic of presentation is stigmatization and mental health in patients with substance use disorder. There was a reason to conduct this study. I have studied, when I was going to plan this study, I saw that, and I read whole literature. So I find out that the stigmatization of substance use disorder is more worse than the stigma of the other psychiatric disorder. Even the patient having schizophrenia, bipolar disorder, and other psychotic disorder having less phenomena of the stigmatization as compared to the stigma of substance use disorder. And there is a perception in society that people having substance use disorder, they are taking their drugs by their own choice. And people, mostly people, instead of the professionals, and even some of the professionals in globally, not in the third world country, they believe that they are taking drugs by their choice. They don't believe till that they are actually the problem is the substance use disorder is a problem, is a disease and a mental disorder. So this was purpose of my study to why I conducted this study, because actually the process of the stigmatization is so painful that they directly affect, in fact, they directly affect the personality and the well-being of the person. People try to avoid the taking treatment because they are stigmatized. And the gentleman asked the question about why females are not included yesterday in the presentation of Dr. Sajid Iqbal. Why they are not included in females, especially in the research? Because due to fear of stigmatization, females don't want to take a treatment. Because they will face in the problem to getting in a marriage, in that they're continuous in their jobs, in the educations. So these are the factors. Either the problem of substance use disorder is so high, but due to fear of stigmatization, females are not taking treatment, especially in third world country, in our region, specifically India, Pakistan, Bangladesh, Sri Lanka. These are the countries where I know about. So my objective to conduct this study was to, this is the main. Thank you very much. Stigmatization and mental health in patients with substance use disorder. In fact, globally, drug taking behavior and drug taking is a big problem. And we can see that in 2021, 1 in every 17 people aged from 15 to 64 years in the world had used drugs. And if you see, this is actually the age which is after the 15 year of when person will have the most potential to serve the society and to do something. Then if person is going to take the drug, so the whole life is going to spoil. The estimated number of users grew up from 240 million in 2011 to 296 million in 2021. That is the big number. Mean 5.8% of the global population aged 15 to 64%. This is 23% increased partially due to population growth. Globally, over 296 million people used drugs in 2021 and increased 23% of the previous decade. So in this decade, there is a huge increase number of the people with the substance use disorder. The number of people who are suffering from drug use disorder, meanwhile, has skyrocketed, like 39.5 million as per 45% increase over 10 years. This is the latest world drug report. And again, cannabis is the most used drugs with estimated 219 million users, which is the 4.3% of the global population, adult population. And use of drug increasing, and although globally cannabis users are mostly men, that is because the mostly world where the mostly peoples in different culture, and especially where in India and Pakistan, where the men's are actually working and females are not, they are taking care of their houses. So where the men are actually taking drugs. So the whole family is suffering by financially, economically, and other stuff. It is estimated that in 2021, 36 million people had has amphetamine, 22 million had as cocaine, and 20 million had used ecstasy type of substance use disorder in last year. The proportion of female users is higher in the case of amphetamine type stimulants. 45% of the user are women, and non-medical use of the pharmaceuticals between, for example, the benzodiazepine, other the drugs which can be used for the purpose of medicine. 45 to 49% of the user are women, where is the highest. And I would like to explain, especially in Pakistan, where the females, this is another phenomena, so where the females are trying to commit suicide by using benzodiazepine or other depressant drugs. So that is why the benzodiazepine and the depressants are more higher in the females. Opioids continue to be a group of the substance with the highest contribution to severe drug-related harm, including fatal overdose. That's very common, especially in the third world countries. The death due to overdose is very common in Pakistan, India, and other such countries. An estimated 60 million people engaged in non-medical opioid use in 2021, which is a 31.5 million of the home use of opioids. Differently, drug postures different burdens on health and healthcare system, of course. Most drug use disorders are related to cannabis and opioid, which are also the drug that lead most people to seek drug treatment, but opioids remain the most lethal drug. Again, the other risk is the risk of acquiring HIV is 35 times higher for those who inject drugs. Where the third world countries are suffering from many of the health issues, and there are not sufficient resources to treat, where it is not possible to them to treat the HIV. So, especially in Pakistan, there are some areas where the HIV is growing dangerously. Then for those who do, and especially in drug use disorder, people who are taking drugs by injecting, there are 35% more higher risk of acquiring the HIV and AIDS. The joint UNODC, WHO, UNAIDS, and World Bank Global estimate for the people who inject drugs living with HIV is nearly 12%, so 1.6 million people. Mean from every one person from the 8 peoples are suffering from HIV and who are taking drugs by injecting. Southwest Asia, 29.3% people, and the Eastern Europe, even in the Eastern Europe, 25.4% are the two sub-regions with the highest prevalence of HIV among the people who inject. Now, like other countries, Pakistan is also a victim of the illicit drug use, and due to its topography, where you can see Pakistan, the west border along with around 1900 kilometers with Afghanistan, and the eastern with the big country which is India. So due to topography of the Pakistan, due to geography of the Pakistan is the most victim of the substance use disorder. The latest available comprehensive drug survey, which was conducted in 2012, and recently I think Dr. Noor is going to conduct another survey, but in which was latest survey conducted was in Pakistan. It was conducted in 2012, 10 years before. The statistic of survey show all type of drugs are common in the Pakistan society. Opioids are used by male, while tranquilizers are used by the females in Pakistan. This survey report exposes that 6.7 million people who uses drugs are between ages 15 to 64 years. Among these drugs, 4.5 million people were drug dependent, which is 0.8% of the population, where heroin addiction is 3,20,000 people were opium users. This is a big number. Cannabis is the most common drug used in Pakistan, as we described previously, that the cannabis is the most commonly used drug also in Pakistan, which is 4 million people, or 3.2% of the addict population. The use of poly drug was also common, and ratio was showed as 1 poly drug user, 5 drug user. It has also been reported that around 19,000 people were using methamphetamine, 4 lakh and 0.4% were injecting drugs. This is another big numbers. The people having drug dependent, from them 0.4% of the drug users are taking drug through injections, where around the 1.5% and 1.6 billion people denotes non-medical use of the prescription of opioids. If you can see, these are the 5 provinces of Pakistan. Balochistan, which is a less populated province of Pakistan. Punjab is the most populated, where is around 1,200 million people living there. Sindh, Khyber Pakhtunkhwa, which is actually Khyber Pakhtunkhwa and Balochistan, which are actually connected with the border of the Afghanistan. So these 2 provinces are mostly affected by the terrorism and as well as by the substance use disorder, because the whole opioid which is transported, because the main routes of the transportation of the substance and drugs which are Afghanistan to the main border of Balochistan and the KPK. So if you will visit ever, you can see majorly the affected province of the Pakistan are these both provinces, Balochistan and Khyber Pakhtunkhwa, because these 2 provinces are attached with the border of the Afghanistan. Among all provinces, the ratio of the opioids, heroin and opium user is high, 1% in Balochistan, where the province of Punjab, where is the most populated province of the Pakistan, 2.9 million people are inject drug user in Punjab. Similarly, in KPK, Khyber Pakhtunkhwa province, in the illicit drug addiction is 10.9% of the population. Moreover, for these enormous numbers of the drug dependent, the resources for the treatment are reported are very low in Pakistan. The whole country, very few drug treatment and rehabilitation centers existed. So still locally people trying to treat the substance use disorder by different local methods to get the person who is taking drugs. If he will take some responsibility to, then he will be fine. So problem in actually multiplying. So that is. It has been noted that drug addiction has worse stigma, as I discussed in the initial slides, that it's more worse than any other stigma of the mental health problem. The hypothesis was, my first hypothesis was that stigma would vary among mild, moderate, severe, and relapse male patients with substance use disorder. And the second, stigma would predict mental health, level of depression, anxiety, stress, and self-esteem, and psychological well-being and loneliness among the patients with substance use disorder in Pakistan. For the purpose of the current study, 508 patients were selected from the different drug treatment and rehabilitation center, which are located in the different provinces and different major cities of the Pakistan, including Punjab, Lahore, Karachi, Quetta, Islamabad, and Faisalabad. Where further the sample was divided further into 4 categories: mild, moderate, chronic, and severe and relapse. Following measures were used: demographic information for demographic form was used, stigma, substance abuse, self-stigma scale was used, depression, anxiety, and stress scale was used, ICP, subjective well-being scale was used, and loneliness scale was used, and along with Rosenberg self-esteem scale was used to measure the variable. Following is the results, and the first hypothesis was approved that stigma would vary among the different categories of the people with substance use disorder. And the second hypothesis was also approved that the substance use disorder, the stigma of substance use disorder would be a strong predictor of mental health issues like depression, anxiety, stress, well-being, and self-esteem among the patients with substance use disorder in Pakistan. Along with all, these are my presentation. I would appreciate if someone have any question. Thank you.
Hello, my name is Samuel from Nigeria. I'm not sure if you can go to the topic of the presentation. Okay, my comment is just very simple. Your presentation should just be a bit more specific. If we have stigmatization, it should be about Pakistan, so that when someone is looking at the content, if it's all about Pakistan, so maybe somehow in the topic, you should have maybe your Pakistan should reflect somewhere in the topic. I think it's very, very important. And if it's in a particular region of Pakistan, it's also important, because anyone can just assume that your work is about the Thai people or the Chinese people. I think it's important. Thank you.
Actually, sir, where I can understand your question, that is the sample of the present study work selected from the different rehab center which were located in the different major cities of the Pakistan. So the whole population of the Pakistan. So it can be, the result can be generalized to the population of the Pakistan. Sir, ma'am.
Okay, I see I have the mic. In that case, maybe you may just localize it to the specific region where it is. I'm just saying so that it should reflect in your topic. It's very important that we have it like that. Thank you.
If you have any other question, we will discuss after the session. Thank you.
Thank you so much for your presentation. Just an observation. I noticed alcohol is not mentioned at all. So is there a spiritual or a cultural nuance about alcohol in your country?
Alcohol? Actually, in the sample of the study, the person, yes, a little bit. I think I will add it up the data of the alcohol users. Even the sample, in the sample, the people having substance of alcohol are included, are the part of the study.
Yeah, can I? Yeah. Actually, just to answer that question, actually alcohol is illegal in Pakistan, so it is not permitted. So that is why he has not mentioned it separately over there. Though the cases were actually, as he has mentioned, yeah, those were there. Yeah.
Thank you very much, all of you. Thank you for all your time. Thank you.
Adenibuyan. May I call you Dr. Peter? It's easily. Because your first name is Dr. Peter. All right, Martin, may I call him Dr. Peter like you? I call you Martin. I know this is your friend from Nigeria. Oh, no, Dr. Peter. Okay, Dr. Peter is a master trainer for Colombo Plan and has an ICAP, and he is a good work for the ISUP national chapter in Nigeria and members of ICUD. He's an active member of the West African region of ICUD there, and instructor at the Lagos, Nigeria University of Medicine. Okay, so welcome, Dr. Peters.
Good afternoon, everybody. I want to thank the organizers of this program for giving us this privilege to also share with you some of those things we are doing in our own little way in my own country, Nigeria. I'm representing Sound Mind Initiative, and Sound Mind Initiative, we are in partnership with Lagos State University College of Medicine, and we are there to train people on the universal treatment curriculum, and the universal recovery curriculum. I'm also certified in those three areas, and apart from teaching people about substance use disorder, I also work in psychiatry hospital Yaba, whereby we're able to get our clients, and also work in other rehabilitation center, whereby we're able to get the client for this study. In course of our discussion this afternoon, we're going to look at the following outline. The first one is introduction. Then we'll look at application of UTC and URC curricula, because we believe that when you train people about all these things we are learning under UTC and URC, how do we apply it, in the real life of helping people that have substance use disorder, especially when it comes to the issue of women. So we also have our area of assessment which we concentrate ourselves on. Then what are our findings? Do we have any challenge at all? Then what are the recommendations that we are going to seek and able to look at, and our conclusion, the references. As part of my introduction, we believe that substance use disorder is a global problem, irrespective of your country, either developed, developing, or underdeveloped country. So we believe that substance use disorder is a global problem. So, there was a survey that was done in 2014 by UNODC, and they came up with estimation that 247 million people, were having substance use disorder. And the same survey was also replicated in 2018, and it was established that 269 million people are having substance use disorder. That shows an increase between 2014 and 2018. So illicit substances in their survey include opioid, which is also known as one of the affect the central nervous system relatively or selectively affect the central nervous system. Then the cannabis, which is more or less categorized under others, because cannabis can fall into any others of the group of classification of substance use disorder. Then cocaine, more or less like a stimulant, and all the other substances they use. So it was discovered that 29 million people between the ages of 15 and 64, they are suffering from drug use disorder, and all these sets of people globally, they need treatment, they need health, they need social care, they need rehabilitation. And looking at women start using substances and become addicted differently from men. So if you have women also using substances, the way they're going to have that addiction is different from the way the main counterpart will also fall into that addiction problems. So the addiction progresses faster, they find it harder to quit, they recover differently from men, and their relapse also, or recurrence, is also of different reasons. So when women's specific needs are understood and addressed from outset, better treatment engagement and successful outcome often followed. Who are we? We are Sound Mind Initiative, a training provider for Colombo Plan in conjunction with Lagos State University College of Medicine, Department of Behavioral Science, Medicine. We established a kind of partnership agreement, we have an understanding in 2021, to partner in dissemination of universal prevention curriculum, universal treatment curriculum, and universal recovery curriculum in the university in Lagos, Nigeria. So we have trained over 50 students in universal treatment curriculum and 15 students in recovery curriculum. We started in 2021, and we are still training more people. So the main purpose of this presentation is just to go into the rehabilitation center and see all these things we are learning, we are teaching our students, are they practicable? Are they applying to our own culture, our own setting? Is it different from what we are doing from a traditional point of view or from spiritual point of view? Because we can design a curriculum, and how do you implement that curriculum to fit in the life of people that you are designing this curriculum for? So we decided to go into the community, and let's start from women. We know men are so large in number, but let's start from few people that we can be able to use. So this faculty of science, these are the people that we decided to go into the community to do the findings. Our sample size of 30 women in residential treatment who were diagnosed with substance use disorder are presented. What we do now, we normally have word round, whereby we present people, and in course of presentations, we're able to identify their needs, and then from there, we're able to pick it up, how best we can help them in course of their residential treatment and follow up after treatment. So our methodology, we are looking at, we did within a 1 year program, we selected participants were seen, all these selected participants were seen at different times. And they were helped with Colombo Planned Drug Advisory Program, that's Universal Treatment Curriculum, Universal Recovery, using allies, that's the family members, especially the intimate members. Their family were involved, and we also sought their support to support these people, because the road of recovery is not just one person's journey, it's the whole family and the entire members of the family have to be part of it. So we encourage them that if they want help, if they want also to reduce the burden of care, they have to be part of the treatment, planning and executing. So apart from that, we also look at recovery capital of the patient and the family members. What do I mean by recovery capital? All the resources that are that are available, those internal and external resources that are available for the client and the relations. We explore that to help our client in their recovery. And recovery, as we all know, is a continuum. It's a continuum process. There's no end to treatment or follow-up. So you keep on, encourage them to do better. Then the venue for this presentation or for this research work was carried out in Solid Foundation Hospital and Midfield Medical Clinic. And we also have mutual support group where I founded a kind of a group, a tripoid. What I mean by tripoid, that is the family members, the therapist, and the client, which I refer to as PPTF, Patient, Parent, and Therapist Forum, where we meet and talk about issues that has to do with substance use disorder and prevention, in fact, about relapse prevention as well. What are selection criteria? Actually, we'll have looked at big number, 100, 200 participants, in this course of study, but it will be too large for us as we are starting just newly, and we don't have that strength. So we started with 30 participants who were on admission and treated at different times. So out of 30, 5 declined, and we were able to uphold 25 of them. Gave a kind of a consent, and they consented. And after the inclusion and exclusion criteria, which we adopted about, okay, do you want to be part of this study, and this is going to take so much time, and 25 of them consented, and we were able to carry them along. We have a treatment planning, and which we were able to execute using Colombo plan. What we did was that we were able to look at the gender. We're not going to talk about men. We're not going to have anything to do with men, but our concentration was going to be on female. So we have 25 clients, and we also believe that there is need for them to have adequate follow-up programs. So what we did was that we follow 25 of them with phone call. As a social worker, it's part of our duty also to remind them about their time for them to come for their clinic and to check if there's any issues that might, make them unable to attend clinic, so that we can, be of help to them. We are still going to see that under our challenges. So we have a clinic days for them, which is on Tuesdays, and looking at attendance, out of 25, 15 were able to attend clinic regularly and punctually, Why 10 have a lot of difficulties is either there's no transportation, or there's no money to buy medication, or there's nobody to bring them to the clinic to see a doctor for follow-up programs. So we have issues with that. So, but out of these 15 that were coming regularly, we also, we didn't give up on them. We're still making sure that their medication were also adhered to as being prescribed by the doctor, in the sense that we're able to make sure that they get money to buy the medication, at the same time be able to use the medication by involving the intimate family members to help us to monitor medication adherence. And apart from that, we also believe that an ideal mind is an ideal workshop. So there's need for us to engage them to do something, not about something so big like that, and let them have something to do. So we enroll many of them into learning hairdressing. We also enroll some of them also in tailoring, and we also allow some of them to be a clerical officer in some of those areas that we have opportunities to link them in area advocacy. So out of these 25 participants that were selected, 15 were able to do well, as I said, and they were gainfully employed and with integration back into the community, and they were being of tremendous assistance in curbing this growing pandemic. When I say pandemic, I would have said epidemic, but when I talk about pandemic, there's nowhere all over the world that you won't find people that are having substance use disorder, especially when it comes to women. So now, some of them are more or less like helping us to go to school, to talk to people about preventions in schools, to talk to students. And some of them are also working in church, like a church counselor, to help those people who have substance use disorder, and able to tell them, I've been there before, so this is the way out. Probably I should share this with you later. This is a case of a client that, okay, let me just quickly share with you. This is a case of DO, one of the 5 clients that did very well. DO, a 27-year-old lady, is a commercial sex worker and a single mother of 1 who dropped out of one of the prestigious private universities in Nigeria. She was in 300-level petroleum engineering and was admitted for 5 different times in different traditional and orthodox centers as a result of psychotic substance disorder or addiction. She is the first child of 2 in a monogamous family setting. However, father had other half-siblings, or she has other half-siblings, that 6 other children from another woman before he married this client's mother. So the sudden death of DO's mother on 28th of August 2015 was a shock to her at all hope lost, the mentor, the friend, advisor, and companion gone. So it's more or less like a problem to her. So she was depressed to the extent of hearing voices, having psychotic features, and she was in a normal state of health, until about 7 years prior to presentation, before we presented her during the ward round. When she was introduced to this substance use, especially Indian M's Kong, when she was about 19 years, when she traveled to Dubai with her mother, for holiday. So according to her, when we, in the course of our clocking and simulation, she said that she was introduced to all these substances, especially Indian hemp, by some men who saw her while she went for window shopping. She was given scones to smoke, which she took from them out of curiosity. What is even there? Let me taste it. Let me see how it feels. She came tolerate, so she cannot tolerate. So that's how she started, and up to now, or then, she can tolerate up to 15 to 20 wraps, of scones on a daily basis. So about the same time, she started using tramadol, and she became dependent with, as she said, diarrhea, running nose, blurry visions. And so she became she can tolerate up to 5 to 6 capsules of 200 milligram daily from tramadol. So she also takes cocaine, which was introduced to her by one of her boyfriends. So she sniffed it, but could not state the quantity she takes, just saying it's plenty. Okay, she feels high whenever she uses it and becomes restless, with itchings on the body whenever she doesn't get cocaine to use, which is more or less like the withdrawal symptoms if she couldn't get to use. So the old boyfriend introduced her to the use of Rohypnol, which made her sleep and used to calm her down from the effect of scones and cocaine. She also take cracks, codeine, diazepam, alcohol, and cigarettes, and she also sniffed feces. That's human feces, which she started at different times and used them in varying quantities. She found her habit by stealing money from. She funds her habit by stealing money from her parents and selling her personal belongings, and parents' valuables in order to maintain, especially when it comes to the issue of crack cocaine, which is demanding. She also make more money as a sex worker because that amount of money that she needs to help her to gain that substances, she can't afford it anymore, so she has to turn to sex worker in order to get, money. So as a sex worker, she realized up to 40,000, per night, according to her, especially if she is with more than one sex partner for the night. So she prefers smoking alone, but also smoking in company of friends, joint in order to get high and have extra energy. However, about a year ago, client's speech was noticed to become irrelevant. Now it started having mental disorder, psychotic features now setting in, showing that he might started having co-occurring disorder, mental health disorder, and substance use disorder. So she said things that are totally not in keeping with the topic of discussion, irrelevant speech diverting from the main topic, and sometimes deviating from topic of discussion. So DO constantly ran away from home to live with destitute and follow drug user in ghetto. So she was not taking care of her personal hygiene. She was not taking care of her only daughter that she has just given abandoned that one, which was taken away from her by her child's parent, paternal grandmother. So psychosocial and psychosexual, she claimed that she has several sexual activities with her cousin and half sibling and enjoyed talking about sex. On the scale of 1 to 10, on her sexual activity, she rated herself 6, which is more or less like, above average, active. And she denied ever being repeatedly forced to engage in sexual activities against her will. That shows that she gave a consent so that she can also make some money. In fact, she prefers to dance naked as a stripper or at a club, holding poles and being touched by customers who give her money. Why? Because she needs money to maintain her substance use. So she enjoys sexual activities with 2 men at a time, which gave her much pleasure than a single man. As a result of her unprotected sexual activities, she had over 5 abortions for different men. So now, concerning URC and UTC, we decided to use this method to see if we're able to penetrate and help our clients instead of taking them to herbalists or taking them to spiritualists. So what we did was we had initial assessment with our client, which is talk about detoxification. Then we asked the medical doctors to place them on MAT. What I mean by MAT, I mean medication-assisted therapy, to make sure that all the withdrawal symptoms will be able to curtail and able to help during that period they are abstaining from that substances. Then we also did screening, using assist, in screening to be able to know which of the substances are they dependent on and how best we can be of help to them. Then we went on to, after that, we want to dig more. Then we use ASI, that's Addiction Severity Index, for assessment, because assessment is different from screening. You have to screen first before you do the assessment. And assessment is more deeper than the screening. So now we're able to identify their needs of these clients, one after the other, using recovery capital based on what we learned in universal recovery curriculum. Case management is also important because there's no how we're able to help this client to harness or to get all the services without having a case manager to help them to do all these things in the area of occupation and able to do well, after treatment. So education, which is more or less like psychoeducation for the patient relations, because many a time before the admission, a lot of them are confused, they don't even know what to do. So there's need for us to do pre-psychoeducation and after, in between, before admission, why they're on admission, and after admission to tell them the stages, how it takes, especially when it comes to issue of stages of change, talking about pre-contemplation, contemplation, and other things like that we have. So we let them understand the stage these clients might be at that point in time. Then counseling is also part of what we use as social worker, individual counseling as well as group counseling. So we also notice some of them have co-occurring disorder, so we refer them to medical doctors who place them on medications, and we're able to follow that they do, and they take their medications at appropriate time. Then, as I rightly said, other mutual support group, we organize PPTF, a special group for women whereby they can come and talk, talk about issues, what's happening in their homes, what led to substance use disorder, and other things like that, which we are able to do for these people. Their relapse prevention training was also, put in place, especially when it comes to supportive counseling. So how do you help them on assertive skills? These are the areas that we're able to help them. Employment training, that is, if you get a job, you need to maintain your job. No matter whatever you have, make sure you do it properly, which is going to really help you, to do well later in future. Then continuum of care, which we also believe that the treatment is a continuum. There's no end to it, especially when it comes to the issue of addiction. So we also have this to share with you, recovery built on care continuum before, during, and after discharge, which we refer to as pre-treatment, treatment, and post-treatment. And looking at pre-treatment, what we did was do the screening, early intervention, pre-treatment, then recovery support services, and which we also did. Then under the treatment menu of treatment services, which we also did with the patient relations and the patient himself, because we believe that you cannot treat the patient alone without the patient himself being involved in it. Because you can't dictate to the patient, so we brought them inside with the relations as well, who's going to also help to fund, some of those areas that we might be need for fund. So recovery support services, including the intimate partner, the alternative services and therapies, which we also talk about, prevention and education for family members, which I also talk about psychoeducation. Then after discharge, what happens next? Continue care for this client, telephone call, make sure they come for clinic, and also make sure that they take their medication. Then checkups, it's part of social worker responsibility to also go and check your clients to see how they are doing, how they are faring at home, at the same time where they are working. Then self-monitoring can also be encouraged. Then I said that recovery capital is also important, which we also used, in helping our client. The first one is family social support. We sought the family help, then safe housing. Many of them were being neglected. Many of them were sent out from home. We were able to bring them and reconcile them back to their parents, because a lot of them have done a lot of terrible things, and a lot of parents, some families have, they have abandoned them. So we're able to bring them back. Then peer support. When they see that I'm all alone, I also need help, and other people are also going to help me. Then employment and resolution, we have talked about vocational skill, community integrations, and cultural support. Then rediscovering and discovering, and meaning and purpose in life, and at the same time talk about mental health. Then we also use readiness ruler. We'll talk about readiness ruler, we more or less like a way of helping to check the motivation level of our clients. To check, are they really motivated? Are they really ready for this? So when we talk about readiness ruler, we are using a kind of from 0 to 10, how ready are you? Invoking chain talk, and we're able to explore this. Then we also move on to look at triggers. What are the things in the environment of our client that might trigger them to, to relapse? So we look at some of those frustration, anger, sadness, boredom, happiness. In fact, some of them say when I'm happy, I take drugs. Some people say if I have money, I take drugs. And some of us tell you that if I don't even have money, I started looking for money because I don't have money, I feel depressed. So I have to take drugs. So how do we help someone that is happy and is using drugs? Someone that is sad is also using drugs. So these are some of our challenges. But at the same time, those are some of those triggers, anxiety. Then we also talk about, look at external trigger, which we also derive, like she will use substance whenever she's with her friend, in company of friends, at nightclubs, when people are dancing and using substances to keep them awake, to be able to do whatever they are doing. Then during a date or before sexual activities to enhance sexual performance, many of them, engaged in substance use, especially when it comes to weekend. Friday nights, Saturday nights, people, engage in drugs and other things like that. During vacation, and holidays. We also use this. This one is from Universal Recovery Curriculum. This recovery plan will of change. So we're able to look at this 0 to 4. What does this stand for? How do we help our client within 0 to 4? How do we help our client from 5 to 6? Then how do we help our client from 7 to 10? They have different stages, and at that point in time, you need to know what is happening to them at each of those stages and be able to help them effectively. So other things we do also make sure that we establish is family support and psychoeducation, which I've also talked about. So I also talk about recovery capital in that kind of diagram I talked about. Then what are our challenges? Lack of computer for researcher. Or some of us were sharing computers, to gather data. When we are trying to analyze our data to check when he's supposed to come for treatment, when he's supposed to go for follow-up, and who's going to follow this one, who's going to do this for this person. So we have a lot of challenges in area of database. Then transportation is also one of our limitations. Then finance for patients, medication. Many of them say, I can't come to clinic because I don't have the money for medication. Some of them will tell you, I don't have transport to come. Some of us have to, pay them, give them some money. Okay, please come to the clinic. They will pay your transport, to and fro. So these are some of those problem. Many of them have to live with relation. They don't have the accommodation of their own, so they still have to live with relation. You can imagine 34, 40-something-year-old lady still staying with mom and daddy's home. So they still need, to be able to be empowered to stay on their own. Stigma and discrimination, which one of my brothers here has presented today about, stigma on the client and affiliate stigma on the family members. How do you help the family members when they have this affiliate stigma? Then collection of data and the other from relations. Some of them were withdrawing. They don't want to give us information because they don't want to disclose all the family issues that is happening. But at times, we get over them to say, okay, don't worry. We are not here to judge, but we are here to help. The lack of fund on the part of researchers, I've talked about our communication barrier. Many of them that we were able to get, we're able to at least speak some dialects, to make sure that they are, able to listen to us. Because if you start speaking English all the time, they say, what do you want? But when you come down and speak our local dialects, they say, yes, this one is for my person, this is my person. So they're able to give you information. Then what are our intentions? What do we intend to do more? With the help of ICD or whoever. We want to solicit for medication-assisted therapy for our clients. So that instead of saying that they don't have money to come for substance, for clinic or whatever, then we can easily give them money to come. Then reach out to 250 to 500 women in our ghettos. We have a lot of them there. But because we don't have enough researchers, we don't have enough people, to go after them. So we are thinking by the grace of God, we'll be able to, if we don't do up to 250, we'll do something better than 25 we did. Then we should be able to offer free screening tests and case, and we have this kind of case manager for at least either 2 or one case manager, let's say 10 clients, if that's not too much. Get at least 10 laptops for documentation so that when I'm typing on, you can also see what I'm doing, so we can share knowledge about what we are doing. Rehabilitate at least 350 women, as I rightly said. If possible, if we can get grants, it will also help us going. Then we want to do more. Please help us to do more. In conclusion, we can see that women's specific needs, when they are understood and addressed from outset, better treatment, engagement, and successful outcome often follow. These are the people, these are my team. This is when we have a universal recovery curriculum training, and these are the people that also do the Colombo training in my unit. So these are my references. Thank you for listening.
Okay, thank you, Dr. Adenibukan. I'm with Sajid from the Center for Alcohol Studies at Spring of Songkla University in southern Thailand. I'm also collaborating with Nigerian researcher from Covenant University, also near Lagos, right? Yeah. So a few comments and maybe sharing also my experience in working in resource-limited conditions. Firstly, very impressive work. Props to you and your team for working with vulnerable groups, including women who are experiencing SUD. I just wonder whether when you present your findings in the publication, you could also include the pre-intervention employment odds. Yeah, because I understand you don't have the comparison group, but I think if you say, they've become more gainfully employed, then the pre-intervention numbers would be helpful to provide evidence of that. Let's see. I think it was very good that you share a story of OF. I wonder whether it would be helpful to also maybe include some of the feedback from the clients as quotations, similar to the way we do qualitative data collection. That would further contextualize kind of how the intervention affect their ability to become gainfully employed. And then maybe sharing anecdotes on, I have a few. So I got one colleague who went on the Hajj pilgrimage and he was about to collect data for maybe 15 pilgrims. He didn't bring his laptop, obviously, but he had a phone or a voice recorder. So it was simply that. And he would do transcription with his staff later, and we published based on that. As for the computer issue, I use this computer when you go on the field. It's secondhand, and I changed the hard disk to SSD, and it keeps extending the function. So this has been used for 5 years already. I got this for $300, give or take. So that might be a way to help overcome the computer issue. Yeah. I think that's it, and otherwise...
I'm forgetting all those questions, though, because it seems we are... So I think I should answer them one after the other, because I might not be able to recall the first question again, because I'm not writing.
I beg your pardon?
Please go ahead with your questions and make it brief so that I can be able to answer. Please.
Okay, so my question is, well, there was sharing kind of ideas, but my question, what was the employment rate pre-intervention?
All right, thank you so much. We believe that many people that have substance use disorder, especially they don't have jobs. Some of them are being laid off because of that substance use disorder. And when we talk about people that have substance use disorder, they have a lot of characteristics. Especially they may not be able to manage money. When it comes to issue of money management, or they might not be able to be really fantastic in that area because all the money, the little money they are having, they're going to use it on substance. Okay? And when you talk about employment, like stigma or discrimination, once you believe that someone is using substance, there's tendency that you might not even want to have anything to do with that kind of person, which more or less like stigma on the person or herself or himself. And we have seen a lot of issues, as a social worker, someone, had issue with substance, and he came for rehabilitation. After we finished the treatment, we were trying to integrate him back, to workplace. And they rejected him. He said, no, he can't work here with us anymore. He has been in psychiatric hospital, he has been this, he has been that. So different kind of name given to that person. So it's not really easy, to convince people that it's more or less like a brain disease can be helped. If the person has been helped, the person can be, go back again to do what is needful or expected of that kind of person. So before coming for for treatment, many of them, they don't have jobs. And that's the truth. Many of them don't have jobs. And some of them that will believe that they are having jobs, some of them have been laid off. Because either they don't keep to time, either they don't go to work at all as a result of withdrawal symptoms or looking for substances, or, because most of the time they're supposed to be at work. They either are at the joint or with friends, doing the drug or seeking. That's where we talk about addiction as a chronic relapsing brain disease that is characterized by drug seeking and use despite harmful consequences. So most of the time might be used in seeking that drug. Most of the time can be used in using that drug, might prevent them from doing what they're supposed to do. I have so many examples, but I don't know if I have all the time, to share experience about someone that works in the bank, get drunk in the morning. So if you come and to deposit money, instead of writing, probably you came with $5. In my record, I'll put $10. And someone is now receiving money. Instead of giving the person $5, I overpaid the person $25. So at the end of the day, when I want to account, the thing is not working. I have a problem in balancing the account for the day. So if you are the employer, will you retain that kind of person in your facility? So many people that have substance use disorder like that, they have different kind of problems. And we individualize the problems and see how best we can help them individually. So we believe that if they can be helped to do something minimal that doesn't require handling money all the time. And that's why we use hairdressing and tailoring. Because it's a skill. Once they acquire the skill, they can do and help people. And with that, they can earn their living. Thank you.
Thank you, Ka. Very great job, Ka. For the next speaker, Ka.
Thank you.
Ka, thank you, Ka. Yeah, welcome. Next speaker, Dr. Naveed. He's completed his PhD from University of Uttara Malaysia and 12 years provide direct clinical service for children, adolescents, and families in clinical and community-based setting. After working in the public and private sector in 2021, he started a state-of-the-art mental health facility in Islamabad that deal with the 7,000 online clients with the addiction, schizophrenia, suicidal, and severe mental health. Welcome, Dr. Naveed.
Thank you. My name is Naveed Sultan, and sorry I am not doctor, I'm a psychologist till now. And I did my MPhil and joined MSF Medicine Sans Frontier. And then I left and I made an clinic that name is Happy Life Psychological Services. And after that, when we, because after the pandemic of coronavirus, we started it online. And there are almost 600 psychologists, those are working with us as a voluntarily basis. And we deal till now almost 7,000 plus patients online. And after that, many of people need intervention to indoor interventions and need for the admission, so that we create this clinic for this purpose. And when we deal many addiction client, after that UNODC trained us for the UTC, and then we start our researches, and till now we publish our 10 researches and almost appeared in 25 international conferences in Pakistan and outside the Pakistan. Today his topic is risk of the self-harm and suicide associated with the specific drug use disorder, reported in 2021 and 22, a population-based cohort study. Its study is cohort, like we are just dealing till now, and in future we will continue this technique. Substance use disorder, all people are, those are working, those are coming to us. We diagnose them at the base of the DSM-5 diagnosis, and at least they are using 1 year of that specific drug, then we call them as a substance use disorder. And self-harm is also very important, because many of people are self-harm attitude before the addiction. So that also be checked. And to self-harm is when injured yourself purpose. People who self-harm do think hurt with themselves, but do not have the ideation of the suicide. And if the suicide, the act of the instance of the taking one's own voluntarily and intentionally life. Objective of this study is to investigate the risk of SUDs that cause self-harm, suicidal thoughts, and suicidal patterns. Chronic use of the drug can affect cognition that may lead to the memory decline, poor decision making, and disturbance thought pattern, and lead to self-harm, suicidal thoughts, and suicidal pattern. And the specific drug is amphetamine. We are discussing about amphetamine. And our question was, the amphetamine is the widespread to cause psychosis associated with the self-injurious behavior and suicidal thoughts attempts. And the risk of the self-harm and suicide is increased due to the substance use disorder. Actually, this is not a plant study. We are the data presenting. We have the database, and we collect and extract the data from our database. Study design is also automatically become the secondary data. And study setting, only one clinic is, we are presenting this data. And sample size, we have 200 patients at that time. We used case history forms and consent taken family and also from the patient, and we are using biopsychosocial and spiritual model after treatment, and also for the data tracking, psychometrics, drug profiles, and psychiatric profiles we are making. And after discharge from the clinic, we also take the interviews from our new psychologists, because many of psychologists can be biased. And the current study is being conducted at registered patient at HLPS, because every patient needs to register with having the unique code. Data was taken and archived in our database. Investigate to factors that can cause specific drugs lead to self-harm and suicidal thoughts. Chronic use of drugs may impair judgment, cognition, weaken impulse control, and interrupt neurotransmitters pathways that is leading to mental health disorders. To investigate all these factors, we use the following methods of assessment. follow-up method in 2022 and 2021, every person who left us, we call them. If they are not calling us after 3 months, we are calling them. And data was only 200 clients and few of female clients also available to examine the effects after drug addiction, extensive history, childhood, family, social, occupational, marital, and pre-morbid personalities were checked, and detailing the history, severity of the drugs and the coexisting behavior related to mental health was assessed for the treatment and diagnosis. This is the database we make in the Excel sheets, and you can see how much we are taking data from them. And only not SUDs, we are also using the DSM, and we use the final diagnosis terminologies of the DSM-5. And many, as you can see, the behavioral issues also examine PTSDs, SUDs, opioid-dependent, drug-induced psychosis, depression. Because many of, already all of them are SUDs, but the dual diagnosis are also checked. And we also use the psychological testing and other data measures, for example, ASI assist, parenting scales, and many of other V-codes checklists that we need, we are using them. Self-harm and suicide associated with the specific disorder 2021 and 2022, you can see that this graph in March 2022, June 22, and September 22 and December 22, we did the follow-up sessions with them. For the purpose of the assessment and diagnosis purpose, psychometric testing were used like depression, anxiety, and stress scale, DAS, drug abuse screening test. Before the assessment, we used the DAST, alcohol, smoking, and the substance involvement screening test assessed. And then we, ASI and other tests, those are the we need. And MMSE also commonly used for the assessing their cognition level. Intervention from the biopsychosocial model were administered on the clients. This treatment includes families, client families, spouse, and the colleagues for the better results. Not only rely on the clients only verbatim, because many of clients may be hide something. So we use the family and the friends and also colleagues. 200 clients were admitted for the residential treatment with substance use disorder. 18% clients with the amphetamine dependency have the history of the suicidal attempts, and 12% have the self-injured behavior and suicidal thought due to influence of the drug. While 15% of the clients' thought pattern were tried to rehabilitate for after the detox, 3% ratio of clients have to diagnose with the other disorder such as neurodevelopmental and neurocognition does not show any improvement, and we do not include them in the final data. The client who have the influence under drug influence have the poor insight, impairment in personal and special orientation, problem solving, poor decision making, and fail to evaluate them own self. This is the graph. Total 200 clients, 18% with amphetamine dependency have the history of suicidal attempt. 12% of self-injured behavior and suicidal thoughts, 15% rehabilitate, and 3% cannot rehabilitate. As 200 clients registered at HLPES conducted on the basis of the secondary data. Based on their result, this study-based substance use disorder can lead to cognition decline that makes individual negative emotional upheaval and even violence. The results supported research question of the study. And implementation, we can use this in the psychoeducation of daily life, literature for the individual intervention. Future counselor can use this, and for the psychotherapeutic intervention, we can use this. And this is the only one clinic and one organization data. This is our limitation. And this is almost 1.5 year data, not fully data. Comorbidities of neurodevelopmental can be a limitation. And genetic schizophrenia, like many of client, if we are, sometimes we can be mistakes because every client is not have the cognition level as the same. So this is also can be limitation. Psychotropics also were used. Many of clients also using them. So we can also say this is the limitation. Gender differences and the verbatim of the client and family is also our limitation. These are the references and questions. Thank you. Yeah.
You can
Thank you for your presentation. This is very interesting. I do have two questions. So first of all, can you tell us a little bit more about the involvement of family and friends? You mentioned that you also included them in the study. So did you reach them out to ask questions? And what kind of question you asked them? Is it a questionnaire, or what is the procedure? Were they happy with that, or any challenges at all? And the second question was about the control variables. So you want to test the association of the self-harm and suicide and specific drug use disorder. So did you control any variables, and can you justify why did you choose those variables to control? Thank you.
Yeah, answer of first question is that because many of patients are not coming by self, they brought by their families or friends. So that is automatically a natural way of the data collection by the family. And sometimes patient is not agreed on that time. Because many of patients are reported by father suicide as the violent behavior. So we are intervening them and crisis intervention at that time. So that is the main. And after 15 days or 20 days when they spend their detox time, then we are giving them the questionnaire for the consent. And if they are agreed, then we are intervening their family and their friends for the further things. And many of clients, when they leave us, and sometimes they change their mobile phone numbers, and we have almost their 3 numbers, one of their family number, one of the client own number, and one of their emergency number. So any number we can contact them because they already gave us the consent. And second question was the suicide related. And suicide is actually very alarming and also culturally sensitive, and in the Islamic point of view, it's also prohibited. But when I started the clinic, I request to the authorities, Islamabad healthcare authorities for this issue, and they said you can make a safety room. Then we make a safety room because many of clients reported for the suicide and active suicide. And every time a person is sitting with them and prohibiting them for the suicide attempt, so we make it for the on the day time for managing them. And for the because many of client is not exposing that I am going to die myself, but they show that the behavior, self-harm behavior, or hanging them, or using the weapon or such kind of things, or using the rope. So we are collected data through this. But we cannot say the person is asking by self, I am going to die, and we are not saying you are going to commit suicide. So the cultural and also religious values are like striking us. Yeah.
Thank you.
Thank you. Welcome.
Any question? More question? Yes,
Yeah.
please.
Okay, thank you. Samuel Zampak from Nigeria.
Yeah, thank you.
I am particularly interested in the area of suicide. When you talk about what you've done using the assist and other instruments, I'm wondering the instrument you use for assessing the risk factors for suicide. Was it an instrument? You didn't mention anything about much about the instrument, or if you have validated it and how it applied with your people, to be able to know if it was culture-based manifestation of something else. Thank you.
For the suicidal scales, we ask them, we are using this. But for the active suicidal thoughts, we cannot use any scale. We are already know they are going to start this activity. So we cannot say the scale is using, and we are saying you are going to try this, or so we are using this scale. Scale is using after many time when they are left us. But at the time of the admission or during the intervention, their thoughts and their behavior, their talking can show the suicidal thoughts and suicidal behavior. Yeah.
Thank you.
Yeah, okay, thank you. Thank you.
So all of the speakers are wonderful job. So any question from speaker the first speaker, second speaker, third speaker, and fourth speaker. Any mention or comment for this panel? Yes, please. Thank you. I
It's
appreciate
me
it.
again. Yeah.
Yes, I appreciate
Thank you. I have a question for Dr. Peter for your presentation because it is very exciting that you have a topic of the implementation of UTC and you are seeing your country because in Vietnam we also try to conduct some training. But we provide, I think they conduct the training for master trainers and trainers, but we didn't really have a chance to start and implement this at a patient level yet. So your sharing and your experience are very are valuable to us. So I want to ask, what are some of the strategies that you apply when you convince your stakeholders and the training your staff to the point that you can apply these tools for the patients? These are very valuable to us in the future. Thank you.
Yeah, thank you so much. Thank you so very much for that question and comment. Should I say comment? All right, so one thing that we decided to do is that we don't just want to be teaching people about universal treatment and recovery, and without texting those things we are talking about. You know, when you are teaching someone about screening tools, we use assist. There's a guideline, there's a way you go about it. So you can teach that in a classroom setting. So how do you apply when you have a client in your consulting room? So that's one of those things that precipitated us, okay, let's go and implement this and see how we're going to be able to, let's see what we're going to achieve. You can teach something in class, but when you go out of a class, you might find out there's a lot of other things in there that you don't even know, that you have to come back to class and discuss. When it comes to the issue of ASI, which is assessment tools, that's Additional Severity Index, it entails a lot. According to the plan, they said we should use 50 minutes to apply ASI. 50 minutes. I can tell you, we're still there 2 hours, still looking at how we're going to gather information based on what we're asked to do. So when you're in classroom and you're asked to spend, when you go to field, you're supposed to use 50 minutes for this. But initially, when you start, you see that you have a lot of challenges in getting all those things, especially psychiatric history, medical history, forensic history, personal history, the biodata, all those stuff that we have under assessment. So you can easily learn that in the classroom. But when you go outside, you see that it's much more than that. And that one was the reasons why, okay, let's take a kind of research. Let's start with women. Let's see how we can use this instrument, and let's see if we're able to help some of them. And that's the reason why I've been given this opportunity to share this with you today. Thank you.
Excellent job. More questions, more comments? Yes, please, come in the front. Group photo, please. Thank you. We are done with the beautiful job.
Yes.